All right, so there's two types of emergency physician. All right, there's type 1. All right, I only treat emergencies. It's got the word emergency in my name. I'm not treating none of this non-emergency garbage. I'm not going to name names here. All right, but you're basically focusing on the life threats, and that's what this specialty was designed to do. And then there's this kind. I treat whatever comes in. You know, I didn't choose this, but look, I'm primary care doctor for a lot of these folks, not because I like it. All right? And then there's that moment that you realize that unfortunately most of what you're treating doesn't really need a critical resuscitation bay. All right? So I'm the second type, and I'm very strongly in this camp, and this is a lecture basically talking about the least boring but most effective ways for you to save lives. And I just really want to help people. Every one of you in this room wrote a terrible personal statement saying, I want to help people. And then you forgot about it because you said, you know what, airway is cooler than getting people to quit smoking. And this is a lecture, this is a rebuke of all of that, all right? So all the data that we talk about is America only. None of this international stuff, all right? So don't think that this is just, in South America people are dying from cigarettes. This data is about America. So this is a chart. I'm going to go through it quickly because otherwise, y'all won't listen to the rest of my talk. So, give aspirin to people that need it, okay? Have you ever had a heart attack? You should probably be on an aspirin. Have you ever had an ischemic stroke? Be on an aspirin. Are you on AFib and you're not on Coumadin? You should be on an aspirin, okay? Now, this gets missed all the time, and when we start doing med recs, it's kind of be on you of why didn't you correct this? Why didn't you see this guy that had a heart attack a couple years ago, eventually ran out of his clopidogrel, or Plavix for those that sold out, and now he's not even taking anything. Why isn't he on an 81 aspirin every day? And the only folks that shouldn't be is if they had a major bleeding event that was kind of related to that aspirin. 15,000 lives a year in this country could be saved if everyone that's supposed to be taking a daily aspirin was. 15,000, all right? Let's talk about illicit drugs. Non-opiate drug abuse, all right? I exclude the opiates, and you're probably going to see why in a minute, all right? They come to us all the time because it turns out if you're using meth, you probably need an ER pretty frequently, okay? You really should be talking to these folks, and you need to link whatever it is that they're there for to their abuse. This sounds basic, and you would think, surely this guy knows that he got into a bar fight because of cocaine. They don't necessarily make that connection as much as you would think. Talk to them about it and recruit family help. And when you discharge them, make sure that they at least have a resource they could turn to if they decide that they want to kick the habit. 20,000 lives a year cost by this. And how often have you seen someone whose all their problems were caused by an illicit drug and you never, ever connected them to help? All right? All you got to do is print out a sheet, make it an option. What about the misuse of antibiotics? All right, this is number 3. And these are going in order of more and more lives saved. So drug-resistant organisms are something that we created, all right? This is not a natural occurring event. MRSA was not caused by evolution. It was caused by us and penicillin, okay? Every time that an organism gets drug resistance, it's usually at some survival cost. That's basic evolutionary biology. These aren't happening if we're not using antibiotics. Some of this naturally happens. When you appropriately use antibiotics, eventually resistance occurs. However, there's a whole lot of crappy antibiotic use out there, okay? So give narrow spectrum antibiotics and only give antibiotics when there's a patient-centered outcome that improves it, okay? Just because it's bacteria inside of your ear with otitis media does not mean that you get better because you're getting an antibiotic, okay? So even if there is an infection that's caused by a bacteria, if there's not a patient-oriented outcome that improves with it, I don't like to do it. And also, this is really important, give the patient anticipatory guidance. This is really important. If you're diagnosing someone with bronchitis, they better be aware of the fact that they're not going to be coughing for 2 or 3 days, but they're going to be coughing for 1 to 4 weeks. That's how bronchitis happens, okay? It doesn't get better right away. What happens if you don't tell them that? They go to their doctor because they thought that they were going to get better in 3 days, and they didn't. And what does that terrible doctor do? They give them a Z-Pack, and that's not okay. And why? Because 23,000 people a year are dying due to drug-resistant organisms. 23,000 people, okay? That is more than double the number of students that go to school here. This slide was actually more inflammatory the first time I went through, and so, we'll say it subtly. I think that if you're giving out antibiotics because that's what makes patients happier, you're killing babies in the future. All right? I just want to bluntly say it that clearly. I don't think that I want my profession associated with you because you have sold out so much. Now, right now, only 23,000 people a year are dying due to drug-resistant organisms. In the future, it's going to get worse. If you talk to people that are into infectious disease, we're entering what is called the post-antibiotic era, which means we're going to have bugs that no known human chemical can kill without also killing the person. This is terrifying. This did not used to exist. Okay? Think of how many abscesses that you've lanced because of MRSA. MRSA used to be an incredibly rare event. You used to be able to get a case report written up when you found MRSA. Now it's called Tuesday on the Depot. All right? This is what's happening, okay? So I agree that Steve is right. That's why they're doing it, is that patients think I need a Z-Pak for my cold, and they're going to go somewhere else and get it. And I welcome them to do that, okay? I do not believe in giving them an antibiotic. There's a reason that government officials have given me the right to write antibiotics and didn't just make it over the counter at Walmart. And that's because they trusted that I would have an opinion and expertise to not give it to everything that walks through the door. Because it turns out a Z-Pak is not a very effective antiviral, okay? Unfortunately, we're going to be entering an era during our lifetime when there are going to be bugs that are going to be killing thousands of people, and we'll have no answer. And they're going to park these people in a wing of the hospital and watch them die. Because it turns out the number of new antibiotics that are coming out every year is incredibly small. The number of those drugs that are actually meaningfully different from the old stuff is essentially zero. There's no help coming. It's not going to be that there's going to be an amazing drug in 2 years. I've looked at the literature. It's not coming. So, trivia question. What was the most commonly prescribed drug in the U.S. last year?
Percocet.
Close. Hydrocodone. Number 1. We did it. And that brings us to number 4, opiate abuse. So I split it off from the illicit drugs because this is a separate thing, and this is partially on us, okay? Used to be heroin was a cool drug to do, and then it fell off the face of the earth. And then a little thing called oxycodone came up, and that's why we're seeing people with heroin, okay? It's because we used to give them percodoodles, and then we stopped giving them percodoodles, and they went to brown tar heroin, all right? That's how it works. And I'm sorry, this is us, okay? So use opiates intelligently, okay? If they have acute pain, emphasis on the word acute, opiates are second to none as far as what can take that pain away, okay? You break your arm, or if I break my arm, I would like a little bit of morphine, please. Thank you very much. It's fine, okay? That's for acute pain, okay? Not chronic pain. We'll talk about that in a second. So check the chart for high-risk behavior. Please don't go through the murder that is electronic health records and get none of the benefits of looking back through the old stuff. You don't have to go to a separate room in the hospital to find out old charts. Look, before you give an opiate to someone, check to see that they haven't been to the ER 10 times in the last few months. Maybe use some of these databases that aren't perfect but are better than nothing to pick up on people that are getting a ton of opiates. I've been humbled the number of times I'm about to write a script for a lot of opiates and found out, oh, looks like a day and a half ago they got 100 Percocet. Okay? This happens all the time. So please actually get some of the benefit of electronic health records and not just all the harm from it. Okay? I'm going to say this next point really clearly. Their life is more important than your patient satisfaction scores. I'm not going to lie to you and tell you that you're not going to get patient complaints for appropriately telling someone with chronic pain that no, I'm not writing you a script for oxycodone. I'm not going to lie to you. That's going to happen. And if it doesn't happen, you're a terrible doctor, okay? If you're not getting complaints from someone that says, oh, I've got back pain forever, and he won't give me oxycodone, you are doing your patients a disservice, and you are killing people, okay? To be quite blunt, that's how this works. You should not continue that pathway. And if you find someone that's addicted to opiates, please offer them a way to get help. Narcotics Anonymous is moderately effective. Turns out heroin's pretty addictive, but there are ways to get these folks help, okay? 24,000 lives a year could be saved by stopping deaths due to opiates. 24,000 a year. So who gets opiates? I just said all these folks that shouldn't, okay? If you've got acute pain for short duration, all right, I break my arm, don't say I'm just going to give you Tylenol. It's okay for a few days. That's all right. For a few days after an acute injury like a fracture, that's totally justified, okay? What about cancer patients? Absolutely. You get cancer, I'm going to hook you up. That's fine. All right. Because it's actually been shown that opiates are appropriate for people suffering from pain related to cancer. And it's very appropriate and links into this group. Terminal patients. Look, if you've got someone, they're on hospice, they got a couple weeks to live, they're having trouble, with something, it's okay. You're not getting most of the side effects of this, but you need to tailor it to what the patient wants. Okay. Are they suffering from inappropriate pain? You should treat it more aggressively. Do they want to have the trade-off of being more alert yet have more pain? A lot of terminal patients actually prefer that. They don't want to just have a drunken stupor for the last 2 weeks. They realize that they're going to hurt from whatever's killing them, but they want to talk to their grandkid, and that's okay. Let the patient help you out with that, but they need to be on hospice. Sickle cell patients, a little bit of controversy here, but that's kind of standard of care for people with sickle cell pain. Really should be acute sickle cell pain, to be honest, looking at the literature, but there's some controversy here. Never, ever for chronic pain, okay? Do not do it. If someone else is making this mistake, don't continue that mistake, and you need to be upfront with them. The problem with opiates is that your brain rapidly adjusts to whatever your current level of oxycodone is, okay? I'm on 0 right now. If you give me a couple of Percocets, it's gonna make me feel better. It's gonna decrease the pain that I don't have, okay? However, if I keep doing that for a few weeks, and this actually begins happening in hours to days, my body gets used to that. And then when you take away that, I actually have pain when I wouldn't have had pain to begin with. It's called hyperalgesia, meaning that people that are chronically addicted to this stuff, you even decrease it, they start hurting. And that sucks, all right? I'm not gonna sugarcoat it. It is a nightmare for these folks. Watching people withdraw from opiates is one of the least pleasant parts of my job. It's terrible. The problem with that is the only way to break this cycle is to stop giving opiates because they won't work. You just keep increasing the doses, okay? If you ever see someone that's on really high doses of Percocet, then they have something like a fracture happen, like an acute injury, they're some of the most miserable people in the world because you cannot give them enough opiates to take care of them because their brain is used when they're not having a fracture, a certain amount of oxycodone. Now they actually have an acute injury, and it's terrible, okay? So keep that in mind, that you get used to this.
For acute fractures, I'll normally write them until they're a week and a half later, follow-up appointment with orthopedics, because ortho, if they come in and see them, and they've dealt with them in any way, they'll usually cover them for the same duration with Percocet. It's still, it's a week and a half, so it's larger than what I normally do, but I think if I broke my bone, I'd probably want that.
And that's controversial. If you look at the pain history of people with fractures, immobilization actually is much more important than opiates. So for the first few days that you have a fracture, absolutely. I think that there's very good reasons, at least 2 or 3 days worth of pain pills. Is it inappropriate to write for a week and a half? No. And I'm kind of somewhere in the middle of that. Some people are really short and they only give 2 or 3 days even for broken bones. Some people are more charitable and give, a couple weeks. But to be honest, having broken bones, after the first few days were really, really painful, at that point, it's a pretty deep ache, but it's not nearly as bad as that first, 48 to 72 hours. So it is a little hard. So let's talk about alcohol abuse. One of my personal vices, I do enjoy beer a lot. So it leads to a lot of traumas. We see these folks all the time. People are addicted. They need some help. How many times have you discharged a guy with alcoholism and you didn't give them any connection about how to actually go get some help if they want to quit? And I know that 99% of the time they're not going to want to quit. At least give them that option. 29,000 lives a year because of ethanol abuse. Secondhand smoke. How many times have y'all worked a peds shift, kid comes in with a cough, and you can barely breathe in the room because the parent smells like smoke? I know it's happened to me. So what really needs to happen is you need to link that patient's visit to what the parents are doing. Kids that have parents that smoke are more likely to get ear infections. They're more likely to have worsening colds. Okay? And that's not because that's the direct cause of it, but it makes you less able to fight it off. Okay? Also remind them that going outside, which is the classic thing of, I go outside. Well, there's a reason that it's hard for me to be in the room with my asthma while they smell like smoke that much. And that's because the particulates stay on your clothes. So even if they truly do go outside, we'll be charitable and say that 100% of the time they go outside to smoke and don't ever light up at home. Well, they're bringing the same stuff back in with them on their clothes. So it's not it's not actually going to fix it. 42,000 people a year are killed because of secondhand smoke. 42,000. That's more people than the county I grew up in had every year. What about hypertension? Another pet peeve. We spent all this time in triage. We got our vital signs. You saw they were really, really hypertensive. And you appropriately said, I can send you home. You're not having end organ dysfunction because of your high blood pressure. And that's fine. But what did you write them? Nothing. And it's because you weren't paying attention. Okay? So I believe in writing hypertensive medications for these folks. Okay? It's not that hard. For some of these drugs, like the diuretics, I would encourage you to get a BMP point of care. Reason being, you want to know their potassium status before you start someone on a diuretic. If they're in renal dysfunction, you probably want to know that before starting them on an ACE inhibitor. You could just write for amlodipine because it's a pretty decent drug and you don't really have to have a BMP to do that. So if you really don't want to get labs, that's okay. Probably not ideal, but it's all right. But if you notice that someone's got a blood pressure of 190, don't say that's because they rolled their ankle. It's not, okay? You can have a little bump in your blood pressure because of pain. It's not going to increase your systolic blood pressure 70 points. That just isn't how it works, and that's not borne out in the literature. So some people would say, look, that's not my job. I'm not a primary care doc. What if they get low? Well, what's going to happen if they follow up with a family practice doc? Are you saying that that person is just magically better at treating blood pressure? No, they're not. They're looking at the same stuff. They're following the guidelines just like you are. So if you're not terrible, go ahead and start them on that drug because it helps the other person figure out whether they need to go up or down on that drug. If you start them on nothing and then magically assume that they're just going to follow up with someone who's a better doctor than you, then that's not going to help them very much because they're going to be in the same place. Yeah?
2 weeks or a month?
So at the risk of being really bad when I'm being recorded, I not infrequently write for a month and I give refills, all right? That's how far on the bell curve I am because I know that some of these folks aren't not just seeing someone today, they're not seeing someone this year. So I have written more prescriptions than I should admit with hydrochlorothiazide 11 refills because I get it. They're not seeing anybody. They don't have insurance. I'm going to still tell them, follow up the Christ community, but a lot of them don't. 65,000 lives a year because of this. What about the sugar beaties? All right. How many times have you guys seen someone, their sugars are really high, you give them some fluids or whatever, and then you discharge them on the same thing that didn't get their sugars under control before? What is wrong with you? They're going to be right back. Okay. So if they're on a low dose of metformin, increase the dose. Be careful when you start tossing around things like glyburide and whatnot because it can make you hypoglycemic. So if you're bold enough to write for insulin or something not named metformin, which is understandably, nervous thing to do, make sure that you counsel them on hypoglycemia and appropriate diet. At the very least, max out their metformin and talk to them about an appropriate diet, okay? At least talk to them. Make sure that they understand that eating breads and pastas is what got them into trouble because a lot of folks think that sugar is just jelly beans. They're totally missing out on the fact that that Italian food that they ate is going to raise their blood sugar just as certainly as a big bowl of jelly beans. Yeah.
So what do you do for the patient that decides that they don't want to take metformin just because of like the diarrhea or something? So, rewriting them for something that they chose not to take before isn't necessarily going to help.
Great question. So the metformin diarrhea actually gets better with time. But number two, I'm actually comfortable writing for glyburide. I'm offended that I'm going to rely on primary care to write a drug that is that safe, and I'm not willing to do it. I'm going to talk to them about how to manage hypoglycemia, how to recognize its issues, and I'm going to send them out. Otherwise, I'm basically admitting that those doctors are better than me, and I've got too much of an ego for that. So 69,000 people a year die because we suck at diabetes. Number 9, nosocomial infections. Please wash your hands. What is wrong with you? Just wash your hands. There's foam on every wall, all right? Every time you go in, every time you come out, wash your hands, okay? When I was shadowing a doctor before I went to med school, he told me the number one way to tell if a doctor's any good or not is you wash them. You watch whether they wash their hands. And if they don't, they're a murderer, okay? Again, it's just terrible. The stuff that's going out there, you just got to wash your hands, okay? But, and this is something, I'm not going to throw stones on this one because I'm certainly guilty of it. How often do you wash your stethoscope head? I know I forget all the time. A very handy thing you can do is basically get some foam in your hand and then just rub it on your hand as well while you're at it. You can get alcohol wipes and stuff like that. You will forget because I do it every time. It's just... Exactly, because we cleaned our ultrasound probes, and why are you still using a stethoscope? 99,000 people a year die because of nosocomial infections, and the majority of those are controlled by appropriate barrier precautions and washing your hands. Sanford Stadium, how many people has it got in it? 92,471 people. 99,000 people. You kill Sanford Stadium every year because we don't wash our hands enough. What is wrong with us? And last but not least, smoking cessation. All right? So this is the one that if you want to do nothing else, if you just fell asleep the first night, and that's fine because they're kind of annoying and it's just mostly me ranting, this is the one to pay attention, okay? When someone comes in with almost any complaint that brought them to the ER, try to link that to their tobacco abuse, okay? And it's not that hard if you understand all the effects that tobacco has. You got a cold, it lasts longer because you smoke. You broke a bone, it's less likely to heal because you smoke and your blood vessels aren't as good. You came in with chest pain, you're more likely to die from that because you smoke. I don't care what it is that they're here for. It probably is worsened by the fact that they smoke, okay? Parkinson's disease may be the only exception to that. So if they didn't come in with an exacerbation of their Parkinson's disease, it's probably worse because they smoke, okay? So there's a few tricks, and this is probably a separate lecture. Don't ask whether they smoke until you listen to their chest. Whether you heard anything or not, they're going to assume that you heard something terrible in their lungs. And they're going to assume that, and that's fine, because I'm not above using tricks to get people to save their life, okay? And always suggest a way to replace. There are some jokers out there that can quit cold turkey. There's not many of them. So suggest a reasonable way to replace, okay? Vapor cigarettes are actually fine, okay? They're not safer than not using anything, but it's very idealistic to think that all these people are going to quit cold turkey. And that's what I suggest. Every time, get them to quit. 480,000 people a year because of tobacco. That's just in this country. It's actually much worse globally. That's more than everything else I talked about combined. All the hypertension, all the diabetes, all those people that are on heroin and cocaine, and you didn't save them. That's double the number of people in this county that we're in. Double it. That's more than actually live in the city of Atlanta proper, all right? We kill Atlanta every year with cigarettes. Atlanta. It's killed over 100 million people in this past century. This is globally. This is not an America fact. That's more than World War I, World War II, Vietnam, Korea, Iraq, and Afghanistan combined. That's cigarettes, all right? Make people stop, all right? Do you have any questions? All right, so break.